Dear colleagues, this is another soft cataract done in subconjunctival anesthesia. We're gonna do the capsulorhexis here using grease Hubbard forceps, a 25 gauge serrata tip, and under irrigation from the AC maintainer. It's very easy to end up with a nice round capsulorhexis. You have a continuous irrigation of the anterior chamber in this way, and the pressure is well maintained during capsulorhexis. And then hydrodissection and hydrodelineation, and rotating the nucleus a little bit with the irrigation needle, injecting some viscoelastic, and then enlarging the ray paracentesis to have main incision. Notice the fact that in this case I try to rotate the nucleus inside the bag both ways. You remember that you only can do that in well sounded journals. You cannot do that in subluxated cataracts or weak journals. So in order to rotate the nucleus and free up the cortical remnants inside the bag, I'm using this spinning technique of Dr. Neto Rosatelli, and then do some horizontal chop. Another horizontal chop, and we'll take out a small eighth of the nucleus, and the pieces will get very easy rotated inside the bag and chopped very well. Notice the fact that I'm trying to chop as much as possible the nucleus in order to have smaller and smaller pieces that mainly you can aspirate them, and in this way at the end of the case you're gonna end up using very low ultrasound, and you have a clear cornea the next day. And second half of the nucleus is getting out very easily, and aspirating the last piece of nucleus, keeping the chopper behind to protect the posterior capsule, and in no time the cataract is out. Was a small or a soft cataract anyway, grade 2, maybe grade 2 plus. And in this case I place the Phaco machine in irrigation aspiration mode, and as you use the irrigation aspiration probe, you can use the Phaco probe also. Notice the fact that anytime I pull back the probe, the sleeve is going forward. That means you have a tight incision. If you have the incision a bit larger, the sleeve will not go forward to the tip of the Phaco tip, and you will end up with the irrigation inside the incision or outside the anterior chamber, and you're gonna lose the anterior chamber very quickly, especially when you try to take the cortex under the main incision. When I do the Phaco polish of the posterior capsule, I don't know if it's noticing here, but I don't touch the posterior capsule. It's just the irrigation that is moving the cortical fibers, and with the help of the chopper I teased out from the posterior capsule and get those aspirated into the Phaco tip. and due to that extensive spinning, the cortex is getting loose, and the last fibers are aspirated out of the eye very easily. And injecting the IOL under irrigation from the maintainer, and then taking out the viscoelastic and from the anterior chamber, from the top of the IOL, and also the under the IOL, and that's about it, and that's the end of the case. Thank you for your attention. I hope this will help you in your practice also.